This is Dr. Julie Huffmeyer with our open anesthesia intraoperative TEE case of the month for October 2011. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. This month we present the case of a 78-year-old man who presents with worsening dyspnea and angina over the past several months. He has been in good physical condition prior to this time, able to play tennis and exert himself physically. When he was seen at his primary care physician's office, he was found to have a murmur consistent with aortic stenosis. Due to his symptoms, his primary care physician sent him to a cardiologist to have a workup for aortic stenosis. He underwent a transthoracic echocardiogram, which showed preserved normal ejection fraction of his left ventricle, but severe aortic stenosis with an aortic valve area of 0.7 centimeters squared, and a cardiac catheterization which revealed non-obstructive coronary artery disease. He is coming to the operating room for an aortic valve replacement. This is part one of a two-part podcast reviewing aortic stenosis. In part one, we will review the pathophysiology of aortic stenosis and the basic TEE views used in the operating room to look at the aortic valve. In part two, we will discuss more in depth the quantitative evaluation of aortic stenosis with TEE. Aortic valve replacement for aortic stenosis is a very common cardiac surgical procedure in patients older than age 65. Probably second most common behind coronary artery bypass surgery. The majority of patients older than 65 who present with aortic stenosis have atherosclerotic changes associated with a tricuspid aortic valve. But as discussed in the September 2011 open anesthesia intraoperative TEE case of the month, patients with a bicuspid aortic valve tend to have abnormalities of the valve that cause early calcification and stenosis. As a first TEE image for our patient as soon as the TEE probe is inserted in the operating room, this is the mid-esophageal four-chamber view at a 0-degree multiplane angle. Of note, the right atrium, right ventricle, left atrium, and left ventricle are labeled. From this TEE view, it appears that our patient has a relatively normal heart. His left ventricle appears to contract well, and from an initial view, the chambers appear to be normal size with normal function. There are multiple echocardiographic views used to image the aortic valve. It is important to take note of the morphology of the aortic valve and to evaluate it from multiple angles and views. This is the mid-esophageal aortic valve short axis view at approximately 40 degrees multiplane angle. The left atrium, and right ventricle are labeled. The aortic valve is seen in cross-section but is not labeled. The valve appears to be tri-leaflet, and there is a significant amount of echo-bright white calcium deposit that is visualized on the aortic valve leaflets. Reduced mobility and excursion of the leaflets are noted. A very small aortic valve opening is seen during systole. This is the mid-esophageal aortic valve short axis view, this time with color flow Doppler placed across the aortic valve. The color is used to help identify any associated aortic regurgitation that sometimes accompanies aortic stenosis, as the stiff, non-compliant aortic valve leaflets don't approximate well in diastole, leading to aortic regurgitation or insufficiency. There is no coexistent aortic regurgitation seen in this view. This is the mid-esophageal aortic valve long axis view, most commonly found at approximately 120 degrees multiplane angle. For our patient, this image was best found at 140 degrees in order to see the left atrium, left ventricle, stenotic aortic valve, and the aortic root. Again, the aortic valve leaflets appear to have significantly reduced mobility, and calcification is easily noted on the leaflets. This is the same mid-esophageal aortic valve long axis view, but with color flow Doppler placed across the aortic valve. Color flow across the stenotic aortic valve helps to show the turbulence in flow that is seen after the stenosis in the aortic root and the ascending aorta. There is a small mild, trivial amount of aortic regurgitation noted. This is the transgastric mid-papillary short-axis view, used most commonly to evaluate left ventricular filling as well as left ventricular function. This patient's left ventricle is adequately filled in this preoperative view with normal left ventricular function. Aortic stenosis causes a progressive increase in afterload to ejection by the left ventricle. This is initially mild, but increases over years as aortic stenosis becomes more advanced. This afterload will increase the wall stress of the left ventricle according to the law of Laplace. As you can see from the equation, increases in pressure P or radius R will increase wall stress or tension. The compensation that occurs is for the left ventricle to thicken in order to minimize this wall stress or tension. Thus, the consequential concentric left ventricular hypertrophy that develops helps to decrease the wall stress or tension on the left ventricle. Eventually, this compensatory mechanism will fail, and the symptoms of aortic stenosis will appear. The resulting left ventricular hypertrophy causes the left ventricle to become stiff and non-compliant, with collagen deposition noted in the muscle. Atrial systole and adequate preload are of vital importance to assist with filling of the left ventricle. A normal atrial systole may be 3 to 4 millimeters of mercury in pressure, but in advanced aortic stenosis, this atrial systole may increase tenfold to 30 to 40 millimeters of mercury. Patients decompensate easily with loss of atrial systole, such as occurs with atrial fibrillation, as their cardiac output significantly decreases due to reduced stroke volume. Symptoms of hemodynamically significant aortic stenosis are important to pay attention to, as they indicate that the disease is advanced, and failure to correct the aortic stenosis will most certainly be associated with poor outcome. The triad of symptoms includes angina, syncope, and congestive heart failure. Angina can occur with aortic stenosis in the absence of coronary artery occlusion because the thick, hypertrophied myocardium restricts the ability of the penetrating coronary arteries to dilate and fill. Coronary artery disease can and does occur in addition to aortic stenosis, and as many as 50% of patients with aortic stenosis will have coexistent coronary artery disease. For this reason, prior to aortic valve replacement for aortic stenosis, patients will undergo coronary angiography. Syncope occurs due to the inability of the heart to increase cardiac output through the stenotic aortic valve in situations such as the peripheral vasodilation associated with exercise. Syncope can also occur with arrhythmias associated with aortic stenosis. Congestive heart failure or dyspnea is the result of the increased preload required to help with diastolic filling of the hypertrophied left ventricle. As impaired relaxation progresses to diastolic dysfunction due to the concentric left ventricular hypertrophy, the preload required to fill the left ventricle increases, as does the left atrial pressure. This increased pressure gets transmitted back to the pulmonary vasculature, thus causing pulmonary congestion and dyspnea. A normal aortic valve is considered to have an aortic valve area of 2.6 to 3.5 centimeters squared. The classification of severity of aortic valve disease is based not only on valve area but on other hemodynamic and clinical data as well. Hemodynamically significant obstruction occurs in an aortic valve area less than or equal to 1 centimeter squared. Listed on this slide are the various levels of severity of aortic stenosis and the associated aortic valve areas. One caveat is that calculated aortic valve areas are estimates based on the assumption that the patient has a good cardiac output. Patients with poor ventricular function and low cardiac output can thus have seemingly low gradients across the aortic valve despite having severe aortic valve stenosis. Their weakened left ventricles cannot muster enough pressure to overcome a tight stenotic aortic valve. There are other methods of evaluating aortic stenosis in patients with poor ventricular function. This will be reviewed in a later open anesthesia intraoperative TEE case of the month. This gross pathology slide shows an aortic valve with severe stenosis due to rheumatic heart disease. The aorta has been excised, exposing the aortic valve leaflets. They appear very thickened and fused. You can imagine that with the heart beating, an aortic valve such as this with severe aortic stenosis would require an increased left ventricular pressure to push blood out through the stenotic aortic valve. In addition, an aortic valve with such severely fused leaflets may also possess some aortic insufficiency, as the leaflets are not able to close fully during diastole. This is a postoperative TEE image for our patient after his aortic valve replacement with his new aortic valve in cross-section, the mid-esophageal aortic valve short-axis view. The bright white appearance of the aortic valve circular ring and the prosthetic components are easily visualized. In addition, the shadowing and streaks radiating down into the far field of the TEE screen are artifacts due to the new valve. This is another postoperative TEE for our patient. The view is a mid-esophageal aortic valve long axis view with the left atrium and ascending aorta labeled. Again, the new aortic valve is seen in the middle of the screen this time in long axis with appropriate mobility of the leaflets. The new valve does cause streaks and dropout artifact in the far field of this TEE image as well. This is the same mid-esophageal aortic valve long axis view with color flow Doppler across the new valve. No associated aortic regurgitation is seen, although the color box may have been more appropriately placed a little farther to the left in order to evaluate aortic regurgitation from the aortic valve back into the left ventricle. In summary, aortic stenosis is a common indication for cardiac surgery and valve replacement in patients older than 65 years of age. The pathophysiology includes development of increased afterload to the left ventricle, leading to concentric left ventricular hypertrophy as a compensatory mechanism. The triad of symptoms portends a significantly poor prognosis without surgical intervention. TEE is a useful tool to evaluate the aortic valve in cases of aortic stenosis and to investigate the long-term consequences of aortic valve disease on the myocardium. Next month, we will review the TEE methods for estimating aortic valve area in aortic stenosis.